Welcome everyone to our webinar series on psychology, diabetes and COVID-19. It's really great to have you all again. Some familiar names there, so it's great to have you back. And welcome if you're joining us for the first time. Please, as always, can you make sure your cameras are off and sound muted just to optimize things at our end? That'd be great. If you'd like to ask us any questions, please do so in the chat function if you're with us on Zoom, and also you can, if you're with us on YouTube Live, post your questions on YouTube. We'll have the Q&A session towards the end, but please do ask questions when you think of them, and we'll note them down and feed them to our guests a bit later on. My name's Vicky Upshur. I work in the King's Diabetes Psychiatry and Psychiatry Research Group, and I'm joined by Professor Khalida Ismail and Emma Constantara, also from King's. Would you both like to say hi?
Yeah, thank you, Rebecca. My name is Khalida Ismail. I'm a diabetes psychiatrist, been working in this area for 20 years at King's Health Partners, which is an umbrella organisation including King's College Hospital, Guy's and St Thomas's Hospital, South London and Wolseley Trust, and the University of King's College London.
And hi, my name is Emma. I am a PhD researcher working on eating disorders in type 1 diabetes in King's College London. I will be taking care of the chat today. If you want to send something to me privately, please double click on my name and I will be able to answer to you straight away.
Thank you both. We are joined by two great guests today. We're really looking forward to it. We're joined by Jen Greaves and Dr. Marilia Garcia. So welcome both. Would you both like to say hello, introduce yourselves?
Hi, yeah, my name's Jen. I've lived with type 1 diabetes for 24 years.
Thanks, Jen.
Hi, I'm Marilia. I'm a psychiatrist and I've been working with people with diabetes for the last year and a half.
Thank you both, and thanks so much for joining us. I'll hand over to Khalida now. Thanks, Khalida.
Great, thanks again, Rebecca. So welcome everybody. Just to give you an outline of the purpose of these webinars, they are an online interactive forum for people with diabetes to talk about aspects of living with diabetes from a psychological perspective, especially within the COVID-19 setup, but hopefully also beyond. This is not a clinical service. If you do have any specific questions about your diabetes or your mental health, please do contact your diabetes team or your GP who will be able to help you. So I'd like to start by welcoming again Jen. Thank you so much for joining us. And maybe if we just start by asking you, I noticed that you introduced yourself as Jen, who's happened to have had diabetes for 24 years, but I was actually interested in a little bit more about you rather than your diabetes, which is, you know, like approximately how old you are, where you live, what do you do for a living?
Yeah, thanks so much, Khalida. Thank you so much for inviting me today. I think the work you're doing is so incredibly important. Well, as I said, I've lived with type 1 diabetes for 24 years, but there are other aspects about me. So I'm 33, I live in London. I work as a digital producer for TV shows, which means I create content for the internet essentially around various TV shows. Yeah, I have been isolating here in London alone, which has been interesting. I'm sure we'll come on to talk about that. Yeah, I guess.
Thank you. And you said, I mean, but one of the things that you put on your social media page is that you're also a writer.
Yeah, so I've been writing all my life, really. I trained as a journalist and went into broadcast for a bit, but I've been writing specifically about my type 1 life for 10 years now, which is quite unbelievable. And over time, that's kind of morphed into various different platforms, so YouTube, and I now have a podcast called Type 1 on 1, and just different ways of hopefully connecting with other people with type 1 diabetes, talking about what it means to live life with type 1 in a real way that doesn't focus on numbers or what's your HbA1c. It's about how it feels to live with type 1, the burden that it can sometimes often feel like, the frustrations, the struggles, but also the hopeful bits and the things I've learned from living with type 1. And I find connecting with others through these various pieces of content and platforms over the years has been amazing for me personally, and yeah, just hopefully it helps people, because it can be quite isolating, of course, to live with type 1.
And so thinking about what you just said, it sounds like you would have been diagnosed when you were 9.
Yeah, 9 days before my 9th birthday. Yeah, it's got a ring to it. Yeah.
Sorry, I apologise. Did you say a day before your 9th birthday?
9 days before my 9th.
9 days. Yeah. Wow. So, what was that like? What was the build up? What was the experience of that like, knowing that you've got type 1 diabetes, being told that?
So I didn't have a dramatic, quote unquote, kind of hospital admission, but obviously it was very dramatic for my 8-year-old self, and also for my parents, in the sense of this lifelong diagnosis. But as an 8-year-old, I definitely didn't comprehend that. In the days and weeks leading up, I had kind of the classic symptoms. I was losing a lot of weight. I was very thirsty. I was going to the toilet all the time. And my teacher, my year 4 teacher, actually found me on a beanbag in her cupboard one break time because I was so tired. I didn't want to go outside and play, which is very unlike me. I barely sit still. So she kind of knew something was wrong. Yeah, and we went to the GP initially. I think one of my first blogs was about my diagnosis, and my mum woke me up in the morning to wee into an empty jar which had contained pickled onions, which was a really dignified start to the condition, but it really set the tone for life with type 1 diabetes, I think, because it is so undignified at times. It's very embarrassing a lot of the time. So we went to the GP with this jar in her handbag and did a blood test, and they sent me off to hospital that day. And yeah, it was diagnosed, but as I said, definitely didn't comprehend what it entailed at the time. And I was very lucky to have, my parents there, and I think they took a lot of the weight on initially, and they must have been petrified. I obviously didn't appreciate that this was as frightening to them, more frightening to them, I think, than it probably was for me. And I'm very grateful to them, because I think that instilled in me a real sense of, nothing stopped because of this diagnosis. I carried on. I was part of like every school club going, and I used to dance a billion times a week. My poor parents taxing me around, goodness. And none of that stopped, I had Lucozade and dextrose in tow, and a blood glucose meter, but I never got this sense that I had to stop doing anything because of my type 1. And I think I've really carried that through life, when new opportunities, be it professionally or otherwise, have been presented to me. I've never really said no. I've kind of said yes, and then figured out where my diabetes will fit into that. Yeah. So I'm grateful.
That's a really nice way of putting it, isn't it? That's a really good top tip, I think, for anybody with diabetes, is don't let diabetes get in the way of your dreams and wishes and passions, and decide what you want to do, and then see how my diabetes needs to adapt.
Definitely, you need to factor it in 100%. I'm abroad a lot, so I'm often away for like months at a time now, obviously not at the moment, with absolute stacks of supplies in tow and backups on backups, and I'm on a pump, and then I've got my insulin for that, and then I've got the number of pumps, and then I've got my backup meters and backup injections and insulin injections and everything. So doing that requires a lot of planning and forethought, but it hasn't ultimately stopped me.
And so what you're saying is that I take diabetes with me. So when did you become like really aware then? Because it does sound like that your parents protected you as a young child and took on, I thought it was really lovely the way you said, my parents, must have been really petrified, but they never showed it, which is a really sort of like an important learning point, I think, is that although that if parents are able to shoulder some of that burden, it allows you to get on with looking after the practical aspects of it, getting on with your life as a child. I think that's a really helpful point. So when did you yourself, as a young person, come to realize, actually, I have got this thing and it is mine, it's not my parents', you know?
Yeah, I mean, I always did my own injections from day one, and I think I was very aware. I was very aware that I had a lot to sort of physically carry with me, and it meant my body changed shape, which was the first thing I think I really noticed as a side of, outside of you know, having to do my injections and test my blood. I did ask my parents recently, because obviously there's so much data now, and I know a lot of parents don't sleep for years and because they're so petrified. And I asked my parents if they were ever told to test my blood at night, and they said no. So I think back then, you know, 24 years ago, it was a case of, I guess we had a bit of ignorance that was potentially helpful to a point. It's a balance, isn't it? I think having all this data and this information is incredible, and it's changed my life completely. But that, you know, you can get so worried about these single blood glucose levels, and I think now, having come so far, you see that those highs and the lows, they're not fun, but they're also not significant if you're doing your best and you're doing what you can, essentially, which is all you can do. I think for me, I do remember my first kind of more dramatic hypo. I think I was only about, I must have been 9, because obviously hypos happen all the time. But I was walking across the fields near my house with a friend, and I carried half a packet of dextrose in my pocket at all times. And that was kind of all we did back then. My parents gave me that and off I went, you know. That must have been so scary to just let me wander off, now that I think about it. And I remember being in this field with one friend and not being able to move, and chomping down these disgusting tablets, because I was very active. I was climbing trees and riding my bike. So by the time I pulled out these dextrose, there'd always be one on the top that was like covered in dirt and dust. So I'd always take that one off. I remember chomping down these dextrose and not being able to breathe properly and having to really sit down. And that I remember that quite significantly. So I must have been about 9 then. And then sort of, I guess, when I went to senior school, and the school was so much bigger and you were so tiny compared to the people 5 years above you, I then suddenly felt less protected, I guess. You know, the secretary at my primary school, we became very close because I used to go into her to do my lunchtime injections and things, whereas from secondary school I was carrying them all myself and deciding for myself when I would do them and when I would test my blood. Yeah, so I think it was probably secondary school onwards. But in terms of the emotional impact, I think that didn't hit me for a long time, and diabetes had inevitably took its toll without me realizing, because all I was ever told was, you know, it was like an equation almost. This is food, this is insulin, take this, do this, equals, you know, blood sugar to the square root divided by what your hormones are doing that day, what the temperature is, how well you slept, whether you've run that day. Like, I didn't know any of that for probably, I'd say 13 years. And by the time it hit me and I realized I wasn't in a great place at all, I think my hormones generally were completely off due to various things, the pill I was on, where I was at in my life. You know, I was 21 coming out of uni. And yeah, it was a diagnosis of background retinopathy that really made me terrified, to be honest.
You would have been, you said 13 years later, so were you in your early 20s?
Yeah, I just finished uni, and the last year or so of uni, I really struggled just in my headspace with my self-worth. I think it had been rumbling for years, and I didn't ever attribute how I was feeling. My diabetes was an add-on, it was an addition. I had no conscious comprehension that this all sort of plays in together and everything impacts everything. I don't know where my hormones start and my diabetes end, or my well-being starts and my diabetes end. It's all this big melting pot. And yeah, I think not consciously given, not knowing, I had no idea why I felt kind of a bit rubbish, but I just thought it was the way I felt, you know. I thought it was just life, I guess. And it wasn't until I realized that the emotional side of diabetes, both dealing with it, what it means to live with it, and, you know, how it makes you feel as a human, was really impacting my well-being and my health that things started to change. But by that point, I was a long way down a road that wasn't very fun. Yeah.
Are you able to tell us a little bit more about that? What you're experiencing? You said, you used the word, I wasn't feeling so well, and I'm beginning to appreciate beginning to understand the burden of it and so on. But what was the actual emotions? Are you able to say a little bit more about that?
Yeah, it's hard to extrapolate my diabetes, I think, from that. I think generally there's a lot going on when you're 21, you're embarking on a new career, you're trying to figure out what's going on in life. And my self-worth was really, really pitiful. I had a huge comparison kind of complex and just didn't think I was up to much at all as a human being. My relationship with food was difficult, to say the least, and my sense of my body. And I don't know that diabetes was necessarily the cause, but I certainly think it made things more complicated. And at that point, I wasn't consciously rebelling from my diabetes. I don't know if that's a very helpful term to use, but I don't think I had room for my diabetes in my head. And I also didn't regard it as something that needed room in my head. I do remember walking past my glucose meter thinking it looked quite dusty. So that kind of gives you an indication of where I was at. I never stopped taking injections, but I can't say, no one had ever explained carb counting to me. I didn't know that was a thing. I think from the people I've spoken to on my podcast who are of a similar age or were diagnosed at a similar age, there's definitely this period where we sort of get lost in the wilds. And I know things are changing, and I'm so thrilled, because it makes me quite sad to look back at that and think of all the energy and time I spent kind of feeling like that, really. Yeah.
And also you would have been, something that comes up in my clinic a lot is that people are making actually a lot of effort in ignoring diabetes or denying it or being angry with it, and yet always at the background knowing that I've got to do something about it. And I always sort of think, I'm always intrigued by that, because it's the same amount of energy that's required to look after yourself. It's always there in the background, so you may as well have it in the foreground. So it's quite interesting you're saying that there was this sort of period of quite difficult, really a type of sort of acceptance, isn't it? That you spent a few years really waking up to the fact that you've got this condition for the rest of your life, because you'd been able to get on with your childhood, not having to think about it too much, which is a blessing. But eventually you do have to accept it, don't you?
Yeah, I can't say I ever didn't accept it. And I know a lot of people do go through that 100%. I never was ashamed of it. I never felt like I had to hide it. I definitely played it down, but I don't think I understood the significance of what it meant to live with type 1 myself. So I couldn't then take that on and have it at the forefront of my mind, because it was never explained to me. So my first term of uni, I also moved outside of uni. I moved 250 miles away. So my care, this transition period, which is such a crucial time, went through 3 or 4 different places, I guess. I was hopping about GP surgeries like nobody's business, just because of going to uni, then getting a bit of care when I was back at home in York, and my previous care had been down south. And I think I fell through cracks that at a time when I really needed someone to explain to me that this was a psychological condition, and that was never ever explained to me. I had to go and find that out for myself after uni. This light bulb went off when I guess I had something to lose, I think, which is what happens for a lot of people. They've met someone and suddenly someone else is telling them that they really need to take care of themselves, or they want to take care of themselves for that other person. For me, I was embarking on a new career. I'd moved to a new city. I was excited by life, and the pill that I can now, I think, attribute to a lot of why I was feeling the way I was feeling. I'd come off it very suddenly because a doctor suddenly told me I shouldn't be on it, but a different doctor put me on it 6 years previously. So I don't know.
So when you say psychological, what are you referring to? What condition are you referring to?
I mean, the psychological burden of living with type 1. I just wasn't aware that was a thing. It would never sat down when I was diagnosed. I remember getting all my equipment and learning how to do my injection, and I would take this many units for this amount of food, and these are the long-term complications. They're very scary, and just never at that, from 9 to 19, that's a 10-year chunk, and it was never sort of, how are you feeling, and this is a lot to carry, like, how are you doing, like, never was asked that. And even when I was 20, I think 7 or 8, maybe coming on to 30, I remember going to clinic, and this is a long way on, and I come a long way, and I did say to my consultant, and I've had amazing interactions over the years, I've got incredible care, and I'm very thankful for that, but I did say, I'm struggling with this. And he chuckled at me, and he was like, well, I'll see you next time unless you find yourself in Bali. And I was just like, what do I do with that? Like, that's not helpful in any way, shape or form.
And that's quite a recurrent theme, isn't it? That people with diabetes do give signals to their health professionals that they're struggling. If it's not the HbA1c going up or not attending for your appointments, you might give some other signals like that. You might actually say, and if it's not received by the health professional, it can be quite damning, can't it? It can make you feel like, what was the point of that? Make you feel like you're being silly, or pull yourself together. So it's quite an interesting observation that you've noticed.
Yeah, and it's just not helpful. And I'm someone who researches and does find things out, and I am now thankfully engaged with my condition and connected to my body, and I didn't uncover all this for years. So I just think people who don't have the headspace or the time to consider these things are more marginalized, and it just makes me so sad, because it's so important. It's as important, because I think once you get these psychological aspects a bit more in the forefront of your mind, or you're even aware of them, that's the problem. I wasn't aware of them. Does it then start to feed into everything? And then I think by proxy, the numbers do improve. I remember being at uni, and I think my GP rang me saying, oh, your HbA1c is a little high, or the hospital care I was under. And it was like, okay, but there was no sort of follow-up or come in, let's talk about this, let's look at what's happening here. It was kind of like, you got to get that down, thanks, bye. Like, so then I carried on crashing about. And
wow. And I thought what was really intriguing about what you just said, about as soon as you are able to acknowledge that there's a psychological component to the way you look after your diabetes, I got the impression you saying that immediately sort of leads you to looking after yourself better. As soon as you acknowledge, I am ignoring this, I'm not checking my blood glucose, or perhaps I'm not giving enough insulin because I'm worried about my body image. As soon as you've got some acknowledgement and responsibility for your own thoughts and feelings, it allows you to sort of look after your diabetes a bit better. Is that what you mean when you said about the increased psychological awareness actually naturally led me to looking after myself?
Yeah, because suddenly I just got sick of feeling sick. I felt so tired, and I was dragging myself through life, even though I had amazing friends, and I was 21, you're embarking on your life, and I just didn't feel excited, and I'd obviously been like, by the time I figured all this out, and it was the threat of retinopathy, it was the threat of losing my sight that did this, that kind of triggered this, which is a dramatic sort of way to come about things, but I guess that's just what happened in my case. And I did start to understand that insulin is a hormone. I didn't know that for 13 years. Like, that's important information, and that hormone would have an impact on everything else that was going on in my body, and that would fluctuate from day to day. And it wasn't just a case of an equation. I could then work with that, and I could interact with that, and I could make choices based on that information, as opposed to being like, well, I'm taking my insulin, and I feel rubbish, so I just didn't click that it would have anything to do with my diabetes.
So taking it on board a bit more. And so what has it been like with COVID then, you mentioned before that you've been in isolation and you've been on your own. I imagine it affected your work load, and so what have you learned about yourself through COVID?
Big question. No, I think, from the people I've spoken to, actually, it seems to have gone one of two ways in regards to diabetes, because life is busy and we're also often just busy doing life and trying to squeeze in our glucose tests or our free boluses and picking up our prescriptions in amongst everything else that's going on. Some people have found that they've had more time to give to their diabetes, which I think has been an interesting point. Certainly my life normally is very busy, run here, there and everywhere, and it's full up, which is how I like it. You know, I feel very lucky to have that. But so slowing down has been interesting. It's allowed me to look a bit more at all the data. I've kept myself moving because, again, it's so important for my mental health. So I've tried to exercise very frequently. I've had to make sure, even, you know, when full lockdown, I kind of got outside every day because I'm in a flat in London and it doesn't have outside space. So just taking my government approved kind of daily walk or run. Running's been a really efficient way to kind of keep my insulin sensitivity up, tick off the exercise box, get out in the fresh air. And I've never run so consistently in my life, to be honest. I think, the workload's definitely slowed down, but the podcast has kept me busy. I'm quite reflective anyway, so I don't think I've been suddenly presented with anything too dramatic. But it's certainly, like, I think people with diabetes are so resilient and so adaptable, and it's just been another set of circumstances to adapt to. I feel like we're doing that every day. I've certainly felt at times more anxious just about the general state of the world and where we're at and the unknown, I think, and you know, I had to come off Twitter for a bit because I felt like it just wasn't helping. It wasn't helpful, just incessantly, you know, seeing those stats and figures at the beginning that were just awful. So I've definitely taken a few measures, but I think life with diabetes is one big assault course of resilience and reacting and responding and, you know, dodging and being agile, and this has been a test for sure, but kind of I guess a bigger version of that, but certainly not something that we're not used to doing, you know.
So it sounds like you took the lockdown in your hand, really, and created quite a lot of structures to make sure that you stay active, that you don't get too bored. Using that time to actually look at your diabetes data a little bit more. I mean, did you find anything interesting about looking at your
readings?
You would have, if you said I love the phrase, my life is full up. The fact that it was less full, did you learn more about your diabetes, the way it ticks, or do you think you're actually doing it already quite well?
Yeah, I mean, over the last 10 years or so, particularly in the last 5, I'm just so in tune with my body now. I make so much space for my diabetes because, as you say, once you realize that, like for me personally, if I make room for my diabetes and allow my diabetes into my life, it then allows me to live my life better, healthier. So I've got better over the past few years at setting boundaries and acknowledging that diabetes doesn't stop me doing anything, but at the same time, it's a very serious chronic illness, and it does sometimes need some attention, and you know, sometimes I need to reset and just say no, which is not something I'm particularly great at, but I'm getting better at it. So I think it's been a slow, steady, ongoing thing over the past few years, but I'm healthier than I've ever been. You know, it just makes me more productive if I make space for sleep, when sleep has been affected in all this some nights, but if I make room and space for sleep, that kind of is the foundation of my general well-being, I think. And then I can see the impact there on my blood sugars. They're a lot more stable and more predictable. If I exercise, I just know that will kick in terms of my insulin sensitivity and not relying on huge amounts and not seeing the numbers move, and then inevitably crashing hypo the other way and all these things that happen. So I think when lockdown hit, I very much knew that the main pillars for me that I needed to kind of keep keep there and not just let everything kind of go. Yeah.
Thank you. So I think we, if we stop there now, Jen, and invite Marilia to join us, and then we'll have some questions and answers, and then we'll probably have some questions and answers, questions for you. Thank you very much, Marilia, for your patience and for joining us. Tell us a little bit about yourself. You know, like, where did you train as a doctor? How long have you been a doctor, and how did you choose psychiatry?
Okay, so can you hear me all right? Yes. I'm originally from Brazil, and part of my family are Italian, so I'm a dual citizen, and I trained as a doctor in Brazil, trained in psychiatry there as well, and then I moved to Italy to train in psychotherapy. And then in 2011, I came to London, and I restarted my clinical training in psychiatry. So I trained twice in the same specialty, which I think it means I really love it. I had no second thoughts about moving specialty. So I've been a doctor for 12 years now, I think, coming up to 13 years. And throughout all this time working in psychiatry, but I'm fairly new to diabetes psychiatry. I've been working in this for just under 2 years.
Yeah. There aren't that many diabetes psychiatrists or psychologists working in the NHS, but one of the things that I've really noticed in all of our webinar series, especially from the health professionals' point of view, is that how sort of culturally and ethnically diverse the NHS is, and that sort of includes myself. And so what it's been like, you know, how is it that you know, why did you settle in England as opposed to Brazil and Italy? You know, it sounds like you have some great choices there.
Good question. Well, my family asks me that sometimes. And I think the reason why I've been staying here for the last, I think it's going to be 9 years now, is that, well, I mean, London is fantastic. And I think the work environment in the NHS, we all know it's not perfect, but there are so many good things about it. I really like the sort of work ethic that the NHS has collectively. I like the fact that there are learning opportunities all the time. So, you know, I've finished my training on paper, but every day I'm still learning. I'm still meeting, you know, new people who are sort of teaching me new things. In Brazil and Italy, I think there are opportunities, of course, but when you come to postgraduate or post-training, there may be fewer opportunities than we do have here in England with so many different services. For example, the liaison psychiatry services, which is the mental health services based in general health services, are not quite as developed as they are here, for example. And why not say it? I love the English weather, you know, like many other foreigners living here. Look at the weather today. Brilliant.
Yeah. Doesn't it? So how about diabetes psychiatry? How did you end up working in diabetes?
So when I was coming up to the end of my training, I decided that I wanted to continue working in the general hospital setting with general patients having, you know, general healthcare problems. Just because I really enjoy the environment of general hospital, and I find that I learn something new about medicine every day. And there were a few jobs, you know, available coming up, and the diabetes psychiatry appealed to me, because during my training, I met a person with diabetes who was my patient for a while, and he had type 1 diabetes. And I remember thinking that I hadn't seen people with type 1 diabetes in mental health services so much. And when we did see them, we didn't talk about diabetes specifically. I just remember struggling with all the different types of insulin and thinking, you know, I need someone to help me make sense of this before I prescribe. So that person actually taught me a lot. He was someone who then went on to do some advocacy and peer support work for other people with diabetes. And I thought that was fascinating. So obviously the team at King's, you know, some of you may be familiar with, is a very well-known team. And it's very innovative because it's not like the diabetes team sees a patient or a person and they're worried about them and they send to a psychiatrist elsewhere. And they may touch base with them or not. It's not like that at all. It's very integrated. So I go to the same team meetings, and I feel that a lot of mental health professionals will feel that we are looked down on by general healthcare clinicians, but that's not the case there at all. I feel like the voice of someone working in mental health is heard and is really incorporated. But also to add, I know it's a long answer, but just to add something really important as I was thinking about this webinar, is that I think working with people with diabetes has taught me a different way of being a psychiatrist, and that is not just about seeing someone for an assessment, finding out which diagnostic criteria they meet, and then proceeding with that kind of pre-packaged treatment. There are so many people I see in my clinic, and I think, Khalida, you may have a similar experience, who may not necessarily meet the criteria for a diagnosis in the psychiatry world, but we still have a role there. And I think it's freeing for psychiatrists to be able to work in this more holistic way.
Yeah, that fits in with what Jen was saying, that when I was trying to get her to tell me a little bit more about what the psychological burden that she was feeling in her 20s, and she didn't actually use the word depression or eating disorder or anxiety, did she? Jen, you said, you know, it was just the burden of living with diabetes. And I was thinking, we don't actually have a diagnostic criteria for that. And so one of the problems is that if you don't have a diagnostic criteria, you don't get the help, because nobody knows, the doctors and nurses don't know what box to tick. So it is an area of, I wouldn't say controversy, it's an area of research and clinical innovation that's still needed, is that when somebody with diabetes has a lot of distress or burnout with their diabetes, how do we identify that and get the help that they need if they don't quite meet the criteria for depression or some other psychiatric disorder? So it's an interesting area, isn't it, in service development to support people. So what kind of, Marilia, what kind of, you know, you mentioned some of the conditions and how it's made you work as a psychiatrist differently, which I think is really interesting. What kind of conditions do you see in people with diabetes, and you know, what's been your sort of observations?
Well, we in our clinics, we see people with all sorts of problems that people without diabetes also struggle with things like depression or anxiety or eating disorders. But there are some things that are quite specific to people with diabetes that I hadn't encountered before in my career. So that's why I feel like I'm learning every day, not just from my colleagues, but from the patients I see as well. For example, something that is very common is fear of hypose. And I think it was addressed in the previous webinar here as well, which in a way makes a lot of sense. As a psychiatrist. If you look into the theory for anxiety, you know, hypo is something that feels awful and it triggers a lot of sensations in your body that are very similar to anxiety, to threat, to a panic attack. So this is something that we see a lot, and it generally is something that it takes a little while to work through and to help that person feel a bit more confident with using their insulin and not fearing hypo so much. Of course, I can't do this alone. I have to work really closely with the diabetes team, and diabetes nurses in particular. They are so knowledgeable about this. It's just really not a job for a psychiatrist to do on their own. Yeah. What else I was going to say, I find that the something that we can even give a psychiatric name for, though I feel like it doesn't fully encompass it, which is when people struggle with the change in the way they see themselves after they have a diagnosis of diabetes. And it may be that someone has diagnosed as an adult and we're seeing them a few months after the diagnosis, like very, very new. And it may be that someone who was very young, who was diagnosed very young and hadn't really had time to think about it. I think Jen was saying a little bit about this in her interview about how as a child she was diagnosed and her parents just got on with it and shouldered her, like you said. And then when she was an adult, she started having to think about it. You can call it a kind of adjustment process, to use psychiatric terminology. But I think the concept of the adjustment disorder in psychiatry doesn't really capture what this really is about. It's more about a number of things like identity. What is it like to be someone with a long-term health condition, particularly if you're a young person and everyone else that you know, all your friends and your cousins and your peers at school don't have anything to worry about. They don't have things beeping, machines beeping on them. So some people find it very helpful, and I've seen and heard this from a number of patients I've seen. some people find it helpful to incorporate diabetes into their identity and be like, you know, I am so and so, and I am a person with type 1 diabetes or type 2 diabetes, and this is part of me. For many people, this is fantastic because it gives them a platform and it helps them connect with other people having similar problems. Whereas other people I've seen don't want to go into that and feel that, well, it's a thing that I have, it's a thing that my body does or doesn't do. It doesn't define me. And I think both of those perspectives and everything else in the middle are valid. So I forgot what the original question was, but the
kind of problems that you see, and I think what you're saying is really interesting, isn't it? Because that's what diabetes, psychiatry, and psychology. This is why we're different from mainstream mental health, because I think mainstream mental health, the way I've come to understand it, is that it makes assumptions that our mental health problems can be resolved. You know, like if you've got depression or anxiety or an alcohol problem, that if you give them this treatment, A or B, either an antidepressant or some psychotherapy, that condition should resolve. But in the diabetes setting, it's not quite the same thing, because you and I have both done this, and there may be people listening here, you know, that I've done CBT with patients, and they've found it very helpful. But as soon as the CBT, and things have improved during the CBT, but as soon as CBT ends, the person with diabetes turns around and says, what now? I've still got the diabetes, you know. And it suddenly occurred to me that actually perhaps some of our models from mental health don't quite apply to people living with a condition for the rest of their lives, you know, a chronic condition, and that we need to develop really innovative ways, new ways of thinking to support people, that this is a relationship they have with their condition that's going to go on for a long, long time. And it's going to keep hitting you intermittently and setting you back intermittently. And how do we help people get back onto a level playing field again? So I think that's really interesting what you're saying. And that's why I think you found yourself moving away from talking about depression to, you know, the psychological aspects of living with diabetes. I also wanted to bring you up on the fear of hypose. Have you noticed any other fears in diabetes apart from hypose?
So many people with diabetes fear complications, which in many ways is very understandable. I think many years ago, patients had messages from healthcare teams that they perceived as very harsh. And I hear now patients telling me, oh, you know, I was diagnosed in the 70s or the 80s or even the 90s. And I was told that if I ate sugar, I would get an amputation. So I don't know, but I went to medical school in the early 2000s, which was actually nearly 20 years ago, thinking of it. And I do remember that the messages that we give to patients changed with time. So I don't want to be overly harsh on the healthcare professionals who gave those messages. I think a lot of them were well-meaning, but they had an effect on a number of people that wasn't very helpful. For some was, like I was saying before, with the individual responses, some people find the identity of having diabetes comfortable and others don't. So similarly, some people find that message of something really bad might happen, they find it helpful and they just spur into action because of it, whereas others go into a fear and avoidance mode. And for some people, this means that they will be really keen to correct their blood sugars and correct too much and go really low. And as we know, sometimes if you go low a lot of the time, then your body may lose the awareness of being low in blood sugar. So that's one fear that people with diabetes have, and a fear of mortality or a fear of being perceived as different by other people. So there's many different fears. They're not just about what diabetes does to your body. You know, for example, if someone has a sensor or a pump, there are fears about what people would think when they see them on the streets, or if someone has to inject and when they are, say, in a train, are people going to judge me and thinking that I'm injecting drugs? So those are the types of fears that I hear a lot. Not to mention, of course, all the other fears that everyone else has, but those are the diabetes specific.
Yeah. And I think some people also develop the fear of insulin as weight gaining, don't they? And I think, Jen, you really you know, when you came around to appreciating that insulin was essentially a hormone that your body just wasn't making, that other people's bodies did make, it allowed you to look at it almost like a mechanical way. Whereas before it was this scary, well, I don't know if it was a scary thing, but something that was, you didn't quite have a handle on, this thing called insulin.
Yeah, I mean more in the sense of how it would impact how I
Yeah.
felt and my body. For me, it was just a drug that I took that I needed to take to keep my blood sugars in a certain range, or hopefully keep them in a certain range. But I didn't have an appreciation or an awareness of how insulin would interact with other hormones in my body and affect things. It was more that I wasn't, you know, I didn't ever think it was scary or stop taking it like that, you know.
Yeah, thank you. So Marilia, just go back to asking you, what kind of approaches do you take, you know, therapeutic approaches in your work?
I think that often just by giving someone an hour, sometimes an hour and a half, to talk about what's been bothering them, what's going on, which we call an assessment, that in itself can often be therapeutic. It's just the approach of being a bit curious, and that's what really got me to psychiatry, which is things happen to people and we have to be careful not to make assumptions. For example, if I start my assessment by saying, so tell me about your diagnosis of diabetes, was it very traumatic? That's not very good, because for some people they would say, it wasn't really, I just took it okay. And my comment of it being traumatic may actually be experienced in a negative way. So I just try to first just be curious. And with some people, they hadn't really taken the time to think about how diabetes affects their mental health. So just being given the opportunity to explore that can be very helpful. Other things, for example, that they are helpful are involving people's loved ones and families, because we know that with a long-term condition that affects the way you eat and your routine. Maybe your family or your partner, or even people who work, I've not invited any work colleagues yet, but I'm just thinking broadly, you know, even people who work with you will react in a way and that will affect you. So I often like to talk to people's partners and families and children, you know, if they're adults, but also if they're children and teenagers, because I think I hear a lot of people who are parents of young children and they have diabetes and they hear their children saying things like, "Mummy or Daddy, are you going to die?" It's very damaging for someone's mental health to be seeing your children react this way. So talking to family and friends, some people, they do get depressed and they do get anxiety disorders outside of those diabetes specific anxieties. In some cases, it can be helpful to consider medication. But I know that some people often don't even want to see a psychiatrist because they fear having the medication talk being, you know, dumped on them. So if I feel very strongly that someone needs to be on a medication, if I feel they will really make a big difference for them, then I may say, look, it's your decision and we can revisit it later. But in many times, I just think that medication is as good an option as psychological therapy. So in my job at the moment, I'm not able to offer formal psychological therapy and see someone every week. So sometimes I have to refer. But with some patients, I see them more often, say, than usually, say every month or every couple of months, to do some kind of psychotherapy, even though it's not in that formal way.
Yeah, and that's partly because of the lack of resources in the NHS for mental health services and diabetes, that we have to spread ourselves quite thinly to make sure we see as many people as possible. I'll be really interested in the questions and answers about people's views about antidepressants, because there are all sorts of, you know, positive and negative views about them. So it'll be interesting to, and if you've got any specific questions about them, you know, Marie would be here to sort of address any concerns people have about them. So Marie, I'm going to stop there because it's we've had such an amazing conversation with you and Jen. I think we could be listening to you both, you know, way after the webinar. But perhaps, you know, we ought to listen to the people that are listening. So Emma, shall I pass over to you? Thank you.
Yes, hi, thank you everyone for participating. We have so many questions for you, Marilia. We will try to answer as many as we can today. If not, the rest will be on our Twitter. So first of all, do you think that invalidation is a common theme in terms of invalidation of impact of diabetes, the effort of diabetes, fears that that a fear can be an overreaction, the depressing feelings that are maybe some people saying that are only related to mental health, etc.
Yes, it's a very good question, and I hear people commenting on this a lot, and how society sometimes doesn't understand what it's like to have type 1 diabetes, for example, or even type 2 diabetes, and to have to look after, to monitor your health all the time. So many people say that they feel invalidated by friends and family who sometimes say, oh no, it's fine, I mean, you have a pump, so you have a machine doing it all for you, you don't need to worry, or you just take your injections, or just don't eat sugar. Or maybe people feel criticized as well, even more than invalidated, but like deliberately actually criticized. And why not say it? Some people have had experience of healthcare professionals who have invalidated them. And I think it generally comes from the lack of education about diabetes for patients, for clinicians who don't work with diabetes. So it's something that in our team, in our service, we like to go and talk to other teams about diabetes and diabetes self-management to try and address this as well. And obviously saying that things are only related to mental health, I guess it's being talked about so many times now, but it's never enough. It's never too many times that mental health and physical health are very interlinked. And saying that something is only related to mental health comes from a misunderstanding, basically.
Thank you. And do you also see people with type 2 diabetes?
We do. We do see some people with type 2 diabetes because there's so many people with type 2 diabetes, and depression and anxiety, other mental health problems are so common. We are not able to see everyone. And if people, particularly if they're not taking insulin, some of the issues can be addressed by their GP or their general mental health services. I think when it comes to insulin treatment, it's a bit more complicated because you get that kind of tiptoeing the fine line between high and low blood sugar that other healthcare professionals sometimes struggle to make a link between that and people's mental health. So that's when maybe our team's expertise is kind of more needed. But we definitely see people with type 2. I do see some people with type 2 who have been recommended insulin and really don't want to take it because of a number of reasons. And even in Brazil, when I was training there, and even family members of mine who have type 2 diabetes, they have this idea often that insulin is bad, that if you go on insulin, it means you're going to go blind. So there's a lot of assumptions. I think there's a lot of scope for for campaigns to talk to people with type 2 about insulin treatment.
Thank you. And do you feel that more information and psychological help should be given at diagnosis? Do you think it would reduce issues later?
I think so. I think some of it can be at a very basic level, just to say, look, people can take a new diagnosis in different ways. And I wouldn't want to say to people like, oh, be mindful that you may get anxiety and depression, or it's more common. I would probably phrase it as some people may struggle. If that's you, then just take time to talk to someone about it, because it's not good to leave it for too long, for example. So I probably wouldn't give too much information about mental health right at the start, but just to acknowledge that it can affect it, and there are ways to talk about it and to get help.
Thank you. And Jen, would you feel the same about information of diagnosis?
It's difficult because everyone copes, just everything about this condition is so personal and unique. I think everyone copes with diagnosis in different ways. I don't know if at 8 years old I would have understood what that meant. I think it's this ongoing thing, as we say, how we feel about our diabetes is an ongoing, you really hit the nail on the head there, it's an ongoing relationship, it's an ongoing evolving relationship. I don't feel the same about my diabetes 1 week to the next, let alone from year to year. So I think those regular touch points that we have with clinicians and the care team, it's important, as you say, to look at what's not being said and get a general sense of feeling. At the point of diagnosis, I think there's so much to take in. But if complications were mentioned, I remember being told that I could lose my legs and my eyesight. So I don't think it would hurt if it was delivered in the right way. It's something, even if you're told at the time and it's not something you come back to for years and years, I think to even have an awareness, certainly for me, would have been helpful.
And I think the point you make, Jen, is the life course, isn't it? The kind of psychological support that is needed is a combination of the age at which you're diagnosed and where you are in your life. You know, so if you're diagnosed at the age of 8, you don't want it. You wouldn't be able to process being told that this is a lifelong condition because you don't have abstract thought. But if you get diagnosed at, say, your mid-20s, you might want to have some psychological support because it's so obviously life-changing to you.
Yeah.
You know, so it's a really interesting question. And I think even from a service improvement point of view, I don't think we quite know how to make sure that we get the right psychological messages and support at the right time. And I know a lot of diabetes health professionals are beginning to do it. In previous webinars, some of the people with diabetes have started saying that their health professional is asking them, how are they at these 6 monthly reviews, rather than how is your diabetes? And it's really been a positive experience for these people. So maybe it's as simple as that, isn't it? How has it been since the last time I saw you 6 months? Tell me about the good things and the bad things. It could be as simple as that, couldn't it?
I think I've said that before, and it is just so important because how I am in general is absolutely going to affect those numbers and vice versa. So if you ask me a little bit about how I'm doing, it's going to give you so much more information into regards as a reason behind the numbers, a bit of context. And I always think the numbers are kind of a symptom. They're not the end point, they're not the cause, they're a symptom of everything else that's happening. So wholeheartedly agree, because I get my height at 33 is probably not going to change, but my mental state, you know, I've been measured my height every single appointment for 24 years, but no one asked how I was for decades and decades. Yeah.
Really, really good observation, Jen. That one about height being measured regularly, but not your mind. So I think we've only got a couple of more minutes left, and I think we're approaching the end. So I'm just going to hand over to Rebecca for our online, this week's online support tools even.
Hello, I'll just share my screen with you so you can have a look at some resources. I want to thank both Jen and Marilia, who sent me some great resources to share today, so thank you. So the first one is Jen's YouTube channel. So if you haven't seen it already, do check it out. She has lots of different videos, lots of different topics related to her experience with diabetes, and also chatting to some others with diabetes also. Jen also has a podcast, Type 1 I've listened to a couple and really enjoyed them. Jen, do you have a favourite or one that you'd recommend for people to start if they haven't listened yet?
They've all got, so if you look at the titles, they've all kind of got a different, just everyone's story is so unique. So I think if there's one that strikes you, I try and put as much information as possible in the info. The last few have really touched on this sort of stuff we've been talking about. Dan and Claire didn't test her blood for, she says, nearly 10 years, that latest episode there. And we cover all sorts of things. It's such a privilege to get an hour to really chat to someone about their life. Dave, who I know is on this call, is there at the top, so I'd recommend that one. Hi Dave. Yeah, so maybe have a look and look at the descriptions and see which ones speak to you, because I've covered a range of topics, ages, you know, all sorts of experiences.
Great, thank you, Jen. And then we have a few mental health related resources. Oh, sorry, I'll just disappeared. So one here is from University College London, is coping with coronavirus. So they have a whole page of resources here, so related to anxiety, social distancing, setting goals, all sorts of things to do with mood and mental health at this time. So let us know if any of these are useful to you. And the final one today is just on the NHS website. It's called Mental Health and Wellbeing, and there's a quiz here you can do to help you understand your mood, and also some audio guides here as well. So.
Great, thank you very much, Rebecca, and also Emma. I think we are approaching the end of this webinar. So once again, thanks very much, Jen and Marilia, for joining us today. It's been really fascinating, and actually we're beginning to overrun, so because there was just so much more that we could talk about. I'm really looking forward to perusing the podcast a bit further as well, Jen. So next week is our last webinar for this term, and we're going to be taking a summer break, but it will be available virtually from then onwards. So look forward to meeting you all again next week, and thank you very much, everybody, for listening. Bye.